Welcome everybody to this morning's Cancer Grand Rounds. I'm really pleased to introduce a guest speaker here today. Professor Jack Lee is the Dean of the College of Medical Sciences and Technology in Taipei, Taiwan. He's a dermatologist by training, but he has had a strong interest and is a proponent of interoperable electronic medical records. And I understand this means a single medical record that is able to be accessible by all providers, inter-hospital and primary providers. He received Taiwan's highest national medical honor for his introduction of a national electronic medical record system. Jack's been invited here to the TCRN to help us set up a bioinformatics course, a cancer-specific bioinformatics course that will be run in conjunction with the TCRN and UNSW. So, without further ado, I'll ask Jack to start his talk today, which is looking at
the big data.
Big data.
Thank you, Vivian. And good morning, ladies and gentlemen. It's a pleasure and honor to be here. I've heard about the Prince Wales Hospital so many times, but this is the first time that I actually be inside a hospital. And it feels very, very familiar because that's also where I work, in a hospital most of the time. But today I'm going to talk to you on some topic that you generally do not hear from a hospital seminar. Okay. I think the first email that's sent to you was about the whole genome of pancreatic cancer or something like that, right? If you're here for that, that's probably next week or the other week. Okay, so that's okay. But so today I'm going to talk to you a little bit about data. Okay, so it's mostly health and biomedical data that we deal with, and when we have accumulated enough amount of data, we call it big data, okay? And I'm sure that as many researchers and clinicians around the world, this hospital and the university also are heavily engaged in translational research. So today I'm going to talk about two topics that's actually a little bit, related to each other. It's the big data and the translational research. Can you hear me all right back there? Okay. This is where I come from. It's a relatively small university in the capital city of Taipei. We have 6,000 students and about 600 faculty members, 7 colleges. My college is one of them. And we have 3 teaching hospitals, about 3,000 beds in total. So we're one of the largest provider in the metropolitan Taipei city. And it's all JCI accredited. We're closest to the world's second highest building. Usually it's first. Now I have to change it to second. But anyway, Taipei 101. Because of this Dubai Tower, that's kind of weird building. Yeah. Anyway, this is the College of Medical Science and Technology, and we have several schools in this college. The School of Medical Technology and the Neuroregenerative Medicine, Biomedical Informatics, Cancer Biology and Drug Discovery, and also Translational Medicine. They pretty much represent the current spectrum of biomedical research in our university. We have a total, in this college, there's a total of 300 undergraduate students and about 150 graduate students, masters and PhD. PhD actually mostly. I'm also the editor-in-chief of these 2 journals, the Computer Methods and Programs in Biomedicine, which is published by Elsevier, an international journal for quality in healthcare, which is published by the International Society for Quality and the Oxford University Press. So what is big data? Big data has to be, of course, big, but how big is big? And it's not just big, it has also to be complex. So if we're looking at a very big phone book, for example, although you've got millions of people in a phone book, it's not considered big data because it's not that complex. It's a very straightforward table, from the first record until the last record. Then we don't consider it a big data. So it is a big data only when it becomes difficult to process using the traditional database. Okay, That's why there are several challenges or several elements. First is the degree of complexity. When we talk about big data, usually it's a joint of multiple tables, maybe hundreds or thousands of tables in different sizes. And the amount of value that can be derived from innovative versus traditional analysis techniques. If we can deal with the database with traditional techniques, usually we don't call that big data, okay? So the use, and also the use of longitudinal information to supplement the analysis, and which is especially true in biomedical database, because as we know, patient's condition changes all the time, and medical records are especially time sensitive, and also a time series database. There are several major challenges. We all know if we have big data set and we have the tool to deal with it, the result is to be expected. We can actually have real knowledge, new discovery. But again, to locate and to access the data and software tool is a challenge. And also, when you get these data and metadata is the data that describe the real data. So we call it metadata. When you get your hands on these things, they are not in the same uniform structure, okay? For example, I'll just give you one very simple example. For example, some database define, patient ID as a 12-digit number. Some other database may define it as a 15-digit, including characters. So even the ID, there's no uniform definition for ID. Each database will define their own ID as long as they're unique and to each patient in their individual database. So there's no standard. And extending the policy for sharing big data is tough because you have some data, I have some data, but why do we want to share with each other? And to organize, to manage, to process these data are difficult. And also, it's challenging to develop new methods to analyze and integrate the big data. And training researchers who can use big data effectively, that will be even harder because typically, by definition, traditional researchers knows traditional methods to analyze data, and big data requires innovative methodology. In the U.S. National Institute of Health, there is a new initiative called Big Data to Knowledge, or BD2K. In this BD2K, they actually started funding all the projects since April this year. The funding are through all layers of biomedical research. It's not like a new grant for big data, then everybody apply for the grant. The grant are integrated with all these different levels of research. So in genomic medicine, there's a big data initiative. In clinical medicine, there's a big data initiative. And everyone can apply for the big data initiative, so they will follow the challenges. They'll address the challenges that we just talked about when they're generating the big data. Sharing, standardization, interoperability, and things like that. There's actually a video on YouTube, but I'm not going to play that to you because of the bandwidth, that they talk about sharing and the incentive for sharing big data. They talk about how to the governance of things, from acknowledgement to authorship. Say, for example, if our hospital, if we generate a big cancer database, why do we want to open it for everybody to use? We spend a lot of money, we spend a lot of effort, and we just put it online so anybody can download it. That's not the ideal model. The ideal model will be whoever use it, acknowledge it, and also whoever use it, talk to the researchers that's maintaining the big data, and eventually maybe a sharing of authorship. That gives the incentive for people to start keep investing this kind of big data effort. And I will give you some examples later of a successful big data sharing model. Okay, so now back to the translational research. I think you've heard many times about translational research, and there are kind of different definitions, and they're evolving definitions. One of this, this is from the Harvard University. It started from Duke, and so many universities now accept that there are 4 stages or 4 blocks. When we talk about translational medicine, we're basically addressing the roadblocks of translation. Say everything started with T1, meaning how do you translate basic science discovery to clinical insights? That's the first roadblock. And then people start to define, divide and conquer all these roadblocks. The second roadblocks is T2, which is a translation between clinical insights to implication for practice. And then from that to implication for population health. And then from that to improve global health. That's why we call T1 a translation to human, T2 a translation to patients, T3 a translation to practice, and T4 translation to population. So as we can see, all the translational research requires data, okay? Many research generates the data, but sometimes we only look at our own research, and if we did not integrate all the data that's generated, then things wouldn't work as we expect it to be. One of the very early example of how big data are coordinated, standardized, and integrated will be the human genome database. I think most of us here heard about how human genome projects are actually divided and spread out into several hundred research institutes and university. But whenever they found a sequence, a segment, they upload it to the GenBank. GenBank is one of them. There are 3 of them, but GenBank is the one that's kept by NCBI under NIH. So if everybody keep their own sequence in their own lab, in the computer and hard drive of their own lab, there wouldn't be a human genome project. It would be just a lot of genes, a lot of segments of DNA in our computers. And sometimes when our research assistant, leave, then everything's gone. And sometimes the hard drive crash, and then we forget about it. And we get more new grants. So that's the bad thing about not having a big data, a centralized repository. So GenBank has demonstrated how that could be. So could be working. Genomics, SNPs, expression profiles, and things like that. People that engaged in T1 research are, I think, more or less they are believers of these, because everybody can only generate so much sequence. Although that's about to change. When I visited the Garvan Center the other day, now they're having all this high-sec 10x machine. That's 10 machine in one, right? So I see from this website saying that they could generate 18,000 genome. They could sequence 18,000 genome, whole genome, a year per machine. So you have 10 of them. That means you can generate 180,000 whole genome sequencing a year. Okay, so that again, that changes the definition of big data. We used to think one whole genome sequencing of 32 billion or 3.2 billion nucleotides, the sequence. It sounds like big data, right? It sounds about right. 3 billion is kind of big. But again, when you look at that multiplied by 180,000, then that's a total different ballgame. Okay, on the T2, researchers on T2 are starting to get the benefit of having an aggregated big data, like clinical trials. Have you ever heard about any example of 2 different big clinical trials sharing data with each other? I don't think so, but they're starting to share metadata, meaning they go to clinictrial.gov and share their metadata. What's their metadata? How many subjects are taking, what kind of study design are we doing, but that's not real data. That's just a description of how they collect the data. But it's a beginning. But registries like cancer registry, autoimmune disease registry, there are many of them, and it's starting to, some of them are getting very big now. Of course, direct extraction from electronic health record, that's also part of my research domain. So on T3, the databases that we're relying upon will be, one example is the EBM database, the evidence-based medicine database. For example, from Cochrane, you've all heard about Cochrane database. And actually, when I talked to one of the researchers in the University of New South Wales the other day, Enrico told me that they just get a multi-million grant from Cochrane to generate systematic review data automatically. So typically, traditionally, what we do is we painstakingly review all these papers around one topic, and we do some meta-analysis, and we generate a report on systematic review on a specific topic. That's very slow and very expensive. And when you look at how many topics we're going to, look at, people estimated there are at least 100,000 topics that we need systematic review upon, and we also need to update it because new evidence are coming up every day. And we're not getting there, and probably will never get there if we're using manual process like human review. Out of this estimated 100,000 topics that we need systematic review upon, we only have about 1,000, so not even 1%. We're closing to this 1%. So we need to gather this database. Also, guideline databases that Robin is working on, some of them, clinical protocols and things like that. Again, on T4 research, people would more rely on insurance claims. I think one good example is the only two countries in the world that actually open all their insurance claims, of course, de-identified, to the researchers will be Denmark and Taiwan. Denmark has about 6 million, 7 million people, but they have been able to keep the cohort to about 20-something years. And they opened this cohort for research. In Taiwan, we have 23 million people. It's about the size of Australian population. Although, of course, the geographical size are much smaller, but the population is about the same. And we were able to open that 23 million people for a 15-year. We keep them like a 15-year cohort because that's how long the insurance has been. And it's been published for the researchers to look at it. And also OTC drug consumption, social networks, and things like that will become the important data sources for T4 researchers. So again, in this recent publication in JAMA, people are talking about finding a missing link for big biomedical data. And then they look at biomedical data like this. It's a very busy chart. I don't expect you to understand them right now, but basically on the left-hand side, these are the structured data. On the right-hand side are unstructured data. So if we look at the red part, the red circle, it says genetics, right? And then across, the genetic goes all across personal health record, 23andMe. If you heard about 23andMe, it's like a $100, $200 genome, testing. And if you swap a little bit and then you send it to them, I think under $200, you will get a check on several, I think they did this whole SNP. They have their own chip, but they did this million SNP, like a whole genome SNP. And they will tell you, okay, after 45, you're becoming, losing your hair, becoming bald and fat and things like that. Yeah, things that we already know. And also things that we don't know, that, there's a 25% chance you'll get diabetes, so things like that, yeah. But again, recently the federal government, the US federal government has a big problem, the FDA has a big problem with 23andMe and ordered them to stop this kind of testing. It's still very controversial. Anyway, so from there, from the personal health record all the way to the medical record, which is here. Okay, and as you know, clinicians, we are not generating a lot of genetic data so far. Partly because we don't know that much about genetics or genomics, partly because the insurance did not pay for it. Okay, in Taiwan, we do have one interesting example is that it's been discovered that one anti-seizure drugs can cause Stevens-Johnson disease. Okay, Stevens-Johnson is a very serious drug reaction and causing blisters and highly lethal. So there is a genetic test that can test the chance. If it's positive, then you have much higher chance. More like the odds ratio is more like 20 or 30. Higher chance of getting Stevens-Johnson from using these anti-seizure drugs. And this anti-seizure drug is a very common drug that people will use. Although this 20 to 30 odds ratio actually means from 0.something% to 2 or 3%. It's still low, but it's higher. So instead of testing for this mutation, the clinician will just order a different drug. Whenever they're in doubt, they order a different drug. And forget about this cheaper and more effective drugs because it causes Stevens-Johnson, so we just forget about it. Because even if it tests negative, it could cause Stevens-Johnson. It's just a chance, right? So anyway, and the insurance did not pay for it until later. So there are still a lot of things going on in this clinical world that's kind of a disconnect with the what's happening in the genomic research arena. So again, this tells you that the heterogeneity of medical data that could possibly be used for big data research to lead new biomedical discovery. So let me give you some examples for the TBI stands for Translational Bioinformatics. It's a big name for using the computer methodologies to help translational research. Okay, so TBI for T1, we've all learned about all the new cancer drug design and drug discovery are based on big data. Target therapy like EGFRI, gefitinib, afatinib, these are all based on big data research. And also there's a druggable genome database. That's one recent example of how big data research are leading the discovery of drugs. And this website, if you go to this DGI or drug gene interaction database, you can put in any genes you want. Let's say I put EGFR, okay, that's one gene name. You can put multiple. I just put one, and it tells me that there are 217 interactions, okay? And the first one is EGFR interaction with a drug called AEE788, and the interaction type is inhibitor. In the middle, you can see the EGFR interacting with a drug called cetuximab. That's actually, I think that's actually a drug that's on the market now. And the interaction type is antibody. And you can click on it and get more information. So it's not just, a single table like you look at them. It's actually a queryable. You can design your own question, and the database will be able to answer some of the questions that you want. So I just talked about TBI for T2. Although we're not sharing clinical trial data in large scale right now, but there are two things that's that's actually good. One is we have this clinicaltrial.gov website. I'm not sure about here. Even in Taiwan, all the trials has to go to clinicaltrial.gov. Yeah. And now if you want to publish some clinical trial, they will ask you, whether you put it there or not. So we did put it there, and there's IRB governance. There's a connection with our IRB unit, or the human research department, to the clinicaltrial.gov. That's one good thing. The other thing is, in the end of a clinical trial, the drug company, if it's a drug company trial, will have to submit data to FDA. And the way they submit data has a standard. It's called CDISC, C-D-I-S-C. Now it's mandatory that all trials that will be submitted to FDA use CDISC as the standard for trial data. Okay, and that has been going on for 3 to 5 years. And now it's like full blown, everybody has to comply with that. Okay, so all this big software, Oracle Clinical, or Phase 1, Phase Forward, all this, big trial data, trial software actually will support CDISC submission already. The other thing, the other interesting example, which I would say would be one of the most successful examples in terms of sharing clinical data from the registry perspective, will be SEER. SEER stands for Surveillance, Epidemiology, and End Results from the National Cancer Institute. It's more about outcome research oriented, but it's a combination of about 18 to 30 hospitals cancer registry, all in a very detailed coding and consistent format, a standard format. We will get to that. Yeah, I will talk a little bit more about it. And also there are publications like Association Between Complex and Mendelian Disease. So because of the attention that's paid to big data, now we're able to study, the relationship between complex disease like diabetes, hypertension, versus Mendelian disease, like all this genetic, so-called genetic disease. When patient asks me, I have, psoriasis, is that a genetic disease? It's hard for me to answer. I would say, yeah, it's related to your, family. But we don't exactly call it a genetic disease, because usually when it's a Mendelian disease, we call it genetic. But again, in the end, every disease is by a broader definition, they're all genetic disease. So I just mentioned that there's a database, the National Health Insurance Research Database in Taiwan, that's open for researchers to look at the big cohort and the big data. I'll show you some examples. So this is clinicaltrials.gov. When I look at it, it has registered about 170,000 trials. And out of the 170,000 trials, 44,000 of them are cancer trials. Okay, and that's for all the trials. If we look at recent trials, the ratio is even higher, So that's also a place to look at metadata. If you want to do research on metadata for clinical trial, that's a place to go. And they're quite open about their data, because these are considered public data. So when you submit to clinicaltrial.gov, it's considered public data, and every researchers can use them. When you have 100 trial, 200 trial, it's not big data. But now when we have 170,000, it become a big database. The other example is SEER, the cancer registry. I checked on it recently, and there's about 7.3 million cancer patients that's registered, that's actually recorded and followed up. So it's not just a one-time recording, it's a follow-up of cancer patient until they die or until most recent. So it has all this, survival data, history of chemotherapy, history of radiation therapy, what kind of surgery, histology type, the pathology. They didn't give you the free text report, but it does encode the report into quite detail, especially for recent data. It's a database that dated back 1973. For the older data set, it's simpler. The data elements are not so many, and the coding are not so detailed, but after 2003, it gets much better. And after 2010, it's very, very detailed. It tells you, if it's a breast cancer, it tells you if it's on the nipple or right upper quadrant, the left upper quadrant, and the lymph node, how many lymph nodes they spread to where. It's all coded in the database. So, and it's open. It's public database. You can just go to the website and print out the form, sign it, send it back. The next day you will get ID password. It's that simple. And then you can access the whole 7.3 million cancer patients. I checked on breast cancer. There are about 200. There are about a lot of them. It's like 1 point something million. The colorectal cancer is almost 1 million. There are a lot of database. So it really is a big database. And when you look at the data representation, each patient are recorded about 170 data elements. And each element, there are elements that's specialized in each cancer. For example, in breast cancer, this data element represents a different coding. The 99 for this data elements in breast cancer means metastasis. In other cancer may mean different things. So there's a very long table that you have to check out. That makes it harder to access, and it makes it harder for so-called traditional analysis. But again, it's very detailed and it's very clinically relevant. We do have a workshop today, and in the afternoon I'm going to show people how to use SEER a little bit. So if you're interested, you can talk to Jason. Jason is the host of the workshop. So we'll go to detail about how SEER work. This is the paper that I talk about. It's just published, or actually it's published this September in Cell. They try to find the association between Mendelian disease and complex disease. So that's a typical big data analysis result, meaning that you cannot look at it and understand what is going on. Actually, you cannot even look at clearly on a paper because the resolution is higher than the paper. So usually you need to download a PDF and then you zoom it to see what's in this table, what's in this graph. So on the x-axis, it's Mendelian disease. On the y-axis, those are complex disease. They did found, so when it's darker, if the dots is darker, that means they're more highly associated. So they did found whenever you have a Mendelian disease, you have higher risk to some complex disease. And each Mendelian disease poses different risk to get the complex disease. So it's more interesting on its methodology. The conclusion is actually not that interesting because it's kind of not hard to imagine. If you have one disease, then your risk is higher risk to get other disease, no matter it's Mendelian or not, right? So if you're old, then you get more disease. If you're weak, you get more disease, of course. So the conclusion is not that interesting, but the process and the methodology is really worth looking at. Okay, we also did something like disease association study, and it's a study that hopefully I can show you in a website if it actually runs. It's a result of a 3-year, 1 billion outpatient visits. Remember when I said we have 23 million people, but how did 23 million people visit their doctors 1 billion times? The answer is simple. We just do it a lot, so we just simply would just visit our doctors 15 times a year for everybody in average. That means some people visit more and some less. I go to hospital every day, but I visit doctors like 5 times a year or 3 times a year. But some people visit a lot. So in 3 years, this population visited their doctor in outpatient setting 1 billion times. So each time we visit our doctor, we generate a sheet of paper or a sheet of data. That data will include several diagnoses. Actually, it's from 1 to 5 diagnoses typically, and a list of medications. Okay, from 0 to something like 30 medications. I've seen patients with 22 medications at the same time. Okay, and actually, I was quite curious and I asked the patient, how do you take your drugs every day? Because you have 23 different drugs. Not prescribed by me though, it's prescribed by their internist. I try to prescribe something to my patient and I look at the list, the current drug list, and I say, oh, no, let's not do it. And I ask my patient, how do you take those drugs right? Because you have 22 drugs and some are twice a day, 3 times a day, 4 times a day, in the morning, after meal, before meal, with water, without milk. And there's so many different restrictions to each prescription, and there are 22 of them. How do you do them right? It's a full-time job. It's actually more than a full-time job to take it right. And he was looking like, I've been through this for 20 years. So what I do is I will pull all the drugs on my table, and depends on the weather and my mood, I'll just put the blue one, the red one, and then I'll put them back. So it's not that hard. Okay, so yeah. No. So that's that's the data sheet. Okay, so several diagnoses plus some medication. An average of 1.5 diagnoses are generated per visit. An average of 3.5 drugs are given per visit. So we do give patient a lot of drugs because our insurance system is a rare example of we actually pay for all the drugs. So the patient will say, if I only prescribe 1 drug, patient will say, why not 2? If I prescribe 3 days, they will say, why not 7 days? And they say, I'm going to go to a travel in this Amazon area, so can you give me 28 days of all the drugs? So they were always asking for more. That's why we give them a lot. So without, in the first few years of my career, I would argue with them, you don't need that many, that's bad for you. And in the end, I'll just do it. So, without wasting this 15 minutes per patient. So we do have a lot of these data and we accumulate the data. So we do some research on the drug thing, many drugs, and we also do some research on the disease. So if possible, see if I can show you. Okay, yeah, it looks like it's getting there. Okay, so we look at all this disease. Yeah, this is going to be a little slow though. Okay, we look at all the disease and all the patients. So 1 billion visits for 23 million patients. For each patient, among the 3 years, about 50 to 60 diagnoses are generated. Okay, it's a bit too, if we can turn it down. So for one patient, about 50 to 60 diagnoses are generated. If 2 diagnoses happens to one patient in this 3-year period, we call that one association. Okay, and we look at the association among all the diseases, and that's the result of it. So we plot the disease like a star. Okay, now it's dark. It looks like a star. The big star means it's happened very frequently. Okay, the prevalence of the disease. A smaller star means that it's not that frequent. For 2 stars that's close means that they are highly associated. If they're far away, it means that they're not that associated, or sometimes negatively associated. So if we look at the sky, the galaxy, the biggest star is here, right? And let's see, if you allow me, okay. So this is the biggest star, and guess what that is? usually takes like 1 second, but now it's taking like 20 seconds. The biggest star is actually upper respiratory airway infection, okay, URI. Because we do go to our doctors when we have common cold, because we need drugs, and drugs free. That's what happens when drug is free, free drugs for everybody. Yeah, it's quite slow. Anyway, so I'm not going to try to do anything tricky. I just tell you that, so by studying this night sky, this galaxy, we get to know, what disease are associated with what and what is with what. So see if I can just do one last thing. Okay, so 250, this is the diabetes, okay? And imagine what is the best friend of diabetes. That would be hypertension, okay? So when we look at the disease galaxy, the disease map, yeah, this is the hypertension. See, hypertension are a little bit larger than diabetes, right? That's what we know. That's what we already know. But you can just look at a map and you directly, feel the power of visualization. So if we shrink and look at the whole galaxy, this is about the position where diabetes and hypertension is, and they're quite close. In this galaxy, they're quite close. So that's one example of the big data research that we were doing with our database. The other example is called the DCAMA, or Cancer Association Map. That doesn't come up. Okay, so let me okay. This is for the rainy days. I just captured the screen. Okay, so it is kind of rainy today. So it's called the Visualization of Cancer Association Map animation. In the disease map, we look at all the diseases. In this map, we only look at cancer versus all the rest of the disease. So we can pick one cancer. In this case, I pick prostate cancer. So you see malignant neoplasm of prostate here. And you can pick prostate cancer versus any disease or all the disease, okay? And if you run, you will see the association of all the rest of the disease versus that one single cancer across different ages. The reason we call it animation in the end is because it's actually an animation of different ages. So there's a 50 there, right? That means this distribution of relationship between the disease and the prostate cancer on a 50-year male patient looks like this. But the chart goes through 51, 52, 53, from 0 to 100. And you can see the change of distribution across the years. Okay, that's why we call it animation. Anyway, so those are just some examples for T2. Actually, sometimes they also call it T3 or T4, but anyway. As I told you, T3, there are new EBM paradigm like machine learning or automatic extraction of evidence out of the papers through literature or text mining. There are guideline database, decision support systems, and all this data accumulated for the purpose of behavioral change for clinicians, which is not easy. What change is not easy for anyone, but for clinicians especially, we don't change at all. Yeah. So for T4, there's a big patient support group called patientslikeme.com. Maybe some of you have seen it. This patientslikeme.com, they have accumulated patient database of all this rare disease. One example is when I check on multiple sclerosis on these patients like me, there are 4,000 patients with the disease on this website actively discussing about what are the treatment, what are the things that they can do to alleviate their symptoms, and things like that. There is no place in the world you can find 4,000 patients with multiple sclerosis. Even in the biggest trial in the world for multiple sclerosis, there will be like 1,000 patients. It's considered very, very big. But now you can find, very big population of rare diseases. And they just, this year, they just licensed their database to a biotech company. I think it's Genentech or Roche, one of these big biotech companies for research, of course, for research into new drugs, I believe. So it's become a very valuable big data. Social network like Facebook, Twitter. In China, there's a Weibo. Weibo is a bit like somewhere between Facebook and Twitter. You're allowed to talk about anything that's related to disease. If it's not, even in China, if it's not about communalism or idealist or following Gong, then it's okay. Disease are all fine. Yeah. So. And then behavioral guidance for large groups of patients. Hopefully, the effort, there's some previous effort from UK, and there's a current effort in Australia about PCHR. Again, both projects, as far as I know, both the UK project and the PCHR project suffers a bit from low participants. Low rate of participation, and there are many, many reasons for that. But again, behavior change is difficult. It's very difficult. Okay, I just asked my son, who is 14 years old. I asked him to, the first thing you wake up in the morning is brush your teeth, and he couldn't do it for 14 years. So, so behavior change is really difficult. Yeah, the first thing he wants is to drink milk. So, which is I don't know. Anyway, this is the website for patients like me, and this is website for the PCHR. So the research paradigm is changing. So from the data perspective, we look at research like there are patient profile, the diagnosis, procedures, medication, that data, and also genome, transcriptome, all this omics database in the middle. And for data scientists, the research is about the interactions among all these data elements, okay, and integration of all the data sources. So what does it mean? I think translational research can be helped by the biomedical informatics. With the big data approach, we can speed up translational research and value add and with more innovation. And collect, share, and utilize. So bigger is better, in database. And major breakthrough actually relies on it. Although it's easier said than done. Again, you do need to address all the challenges that I talked about. Because we have the experience of trying to share a big data set with people, but maintaining this effort itself is very costly. And if you don't get any acknowledgement, then it's hard for you to get any other grant or future grant to sustain this effort of sharing the data. So it sounds easy, like just share the data, put a file on the some Dropbox or file server, and then people download it. That's it. But it's not. That's not it, because we're talking about scientific, research quality level data that needs to be maintained. Like SEER actually is a multi-million budget, yearly budget from the NCI in order to maintain that database. And when you look at the coding scheme and the effort that they try to clean the data, you understand why it takes that much effort and money to do it. All right, that will be less my slide. Thank you for your attention.